Hello, welcome. Welcome to the first of our fetal alcohol spectrum disorder webinars. I'm Kelly Henderson with Forum Families Forward, and we're going to get started in just a minute more. Lots of folks are coming in, so we're just going to give them a chance to catch up with us, and then we will get going. If you're just joining us, welcome, welcome. We're going to get started in about 30 seconds. This is the Forum Families Forward webinar, first of our FASD series on instilling hope. All right, we'll go ahead and get started. Again, I'm Kelly Henderson with Formed Families Forward. I am so thrilled to welcome you to the first of this series on FASDs, and very, very, very thrilled to welcome our first presenter, Melissa Ellickson, who is representing the FASDs organization. She will tell you lots more about that organization when she gets started in just a moment. I'm also joined by Lisa Matthey, who is our administrative and training coordinator at Formed Families Forward. Welcome, welcome. We're going to go ahead and first stop on our journey is a little bit of housekeeping with GoToWebinar. I know this may not be the platform that you're most familiar with. So we wanted to give you just a little bit of an orientation. Hopefully you have a panel of pods on the right-hand side, probably of your screen. Those are the bluish grayish bars. When you click on one of those bars with the down arrow, you'll get options. You can see that there's audio options, and there's also a questions pod. So we would very much like you to use the questions pod as you have comments or questions. Chat that in, and we will make time for those. Lisa will help me sort those out so that we can give Melissa the most succinct questions and comments we can. In addition to the questions pod, there is a pod called handouts. So you will click on that, and you can find a copy of the slides for tonight. So you're welcome to access those anytime. That doesn't include these introductory slides that I'm going to present, but it does include all of Melissa's slides. Other housekeeping. Know that the recording of this will be on our website. The slides will be available upon request after the fact if you don't download them out of your handouts pod right now. So again, I'll say that the handouts pod gives you access right now to the slides. If you're watching this in recording, you are going to need to access the slides by requesting them directly from Melissa, and her email is on the last slide of her presentation, and we will put it in the chat box as well.
Absolutely.
Finally, if you would like a certificate of attendance for this session, please email info@formedfamiliesforward.org anytime after this session, and we will be able to confirm your attendance and send you that certificate.
Sounds good. And Kelly, will we be doing questions
All right. Very quickly, if you don't, thank you for joining us. We are a family-led resource here in. We will do questions at the end. Yeah. Okay. We are a family-led resource center in Northern Virginia. We focus our services on foster, adoptive and kinship families who are raising children, youth, and young adults with special needs of all types, as well as the professionals who partner with us and our families. We offer free training like this one, in person and by virtual means. Consultations, so educational consultations are free of charge. Events, resources, systems navigation. We also have peer support groups, which I'm going to talk about just a bit more after this slide. We have webinars, virtual trainings, youth classes, lots of videos, and other resources. We also serve as the family partner to Virginia Tiered Systems of Supports, or VTSS, which is a Virginia Department of Education project. If you are an educator, you may be familiar with MTSS or VTSS, and we represent family voice on that project. My email is there at the bottom. Lisa's email is there at the bottom. If you have any questions or needs after this session, feel free to reach out. Wanted to just share an upcoming event that's coming up next week, a week from tomorrow. On January 14th, we have a webinar at lunchtime on self-care, how to care for you in 2022. And that's with Dr. Monique Liliakos. And she is going to really bring some excellent information about self-care, especially with a focus on our kinship care providers. But it is open to anyone, and the link there, I think Lisa, I can't see, but I think Lisa is putting that into the chat box.
Yes, I just did that.
Thank you. And as always, you can find everything on our website. If you ever didn't catch the link, you can always go to formedfamiliesforward.org. I wanted to mention those peer support groups just a little bit more detail. We do have a youth and young adult peer support group that meets twice a month in person in Fairfax. And that's on Tuesday nights from 6:30 to 7:30. They are clinician led. We have two fabulous clinicians, Kim and Markia, who lead that group with their peer participants, and you can access again through the link that I think Lisa's putting in the chat box. And we're not leaving our parents and caregivers out. We have two separate options for peer support for parents and caregivers. These are for adoptive and foster parents and kinship caregivers. We have a virtual group that meets the first Monday of each month, except this month, which is actually the second Sunday, which is this coming Sunday. Lisa leads that. So if you are interested in that group, that first next meeting is this Sunday, the 9th. And then we have an in-person group on the third Wednesday of each month. And that again is at our offices in Fairfax City. And all of those groups are led by trained parent providers, and two of our staff lead that, and then a volunteer leads, co-leads one of those. And again, links provided to you. Wanted to just mention that we have, as I noted that at the start of this, we have 3 more webinars in this series after Melissa's. Next week, FASD diagnoses, which is a real challenge, I know, for many families who are just entering these waters. And Dr. Turchi is a pediatrician and is going to share a lot of very helpful information about the range of diagnoses, as well as strategies and tips that families should know as they seek out a diagnosis. The week after that, we have Dr. Malayans from Emory University, who's going to talk a lot about evidence-based practices and the interventions and supports that really work for children who have been prenatally exposed. And then I'm going to wrap up the series with a focus on schools. And that concludes our session, and I'm going to stop sharing myself and have Melissa take over. At any time, again, please use the questions pod to contribute your questions. And Lisa and I will be monitoring that. Let me make Melissa our presenter. And we will do our best to feed those questions to you, Melissa, as the night wears on, but we will let you present and then do some questions and answers. And again, thank you so much, Melissa, for being here.
Oh, thank you so much for having me. Let's see if we can get my technology working here. Oop. Can everybody see my screen? Can you see that, Kelly?
Yes. Yes.
Wonderful. Thank you.
Go.
Okay. For some reason, I still can't see all of you, but you can see me, and I guess that's what's important. I am Melissa Oickson. I am a program director for FASDs, which is based out of Portland, Oregon. But in tonight's capacity, I'm actually a certified facilitator of their neurobehavioral model. FASDs is an organization that is here to train and do consultation regarding fetal alcohol spectrum disorders and other neurobehavioral conditions. And so I came to FASDs about 8 years ago. I am a counselor by trade living in Roanoke, Virginia, all the way down in the mountains. And I came with a lot of questions because what I was doing wasn't really working for people. And so I found the same families coming back to us over and over again. And so I sought out Diane Malvin at FASDs and began to understand that fetal alcohol spectrum disorders and neurobehavioral conditions really need to have a different way of working with them. And so by finding this model 8 years ago, I was able to begin working with my clients very differently and to have better outcomes and better successes and to help them feel better about themselves. I also use it in a personal capacity in my own family because we have neurobehavioral conditions in my own family. And so thank you all for being here tonight. I'm so excited that you're here, and we'll get started. So this is based on the work of Diane Malvin. So 4 main points to think about tonight. FASDs, we know, are an invisible brain-based disability or brain difference with behavioral symptoms. We know that those standard ways of dealing with behaviors really target their symptoms, or a neurobehavioral approach really targets, really recognizes the behaviors and the symptoms that they're having. Reframing behaviors and shifting from symptoms to the source, which is the brain, really redefines problems and solutions in a manner that's really consistent with our research. We know that by looking at a brain-based approach, it really works, and it is applicable to any brain-based difference. And we're going to talk a little bit about brain-based differences. The foundation of our neurobehavioral model is that research has shown the following. Let's see if we can move my screen around a little. Whoops. Oh goodness, sorry guys. How do I minimize my panel? Sorry. Okay.
It looks good to us.
I can't see, for some reason I can't get rid of my panel to minimize it. Is there a way to minimize? There we go. Thank you. Perfect. Wonderful. Sorry, not used to the technology. So research has shown the following, that alcohol, drugs, and other tetragens, and we know trauma, impact that cell growth and cause those physical changes in the brain. We know that physical changes in the brain really affect that structure and the function of the brain. And we know that behaviors are usually the only symptoms that we see. And so when we talk about FAMB, we're talking about fetal alcohol spectrum disorders and neurobehavioral conditions. They're an invisible brain-based physical disability. And we're getting away from using the word disability into the idea of brain-based differences. And we know this is supported by research. So if we agree that FAMB, fetal alcohol spectrum disorders, and neurobehavioral conditions are an invisible physical condition, then providing accommodations for people with FAMB is as appropriate and effective and as ethical as providing accommodations for people with other physical disabilities. So we know that if an individual has a visible physical disability, we provide them with those accommodations. When we take a look at those individual physical brain differences, providing accommodations for an individual who's affected is appropriate and it's ethical, and it reduces that anxiety and that frustration, and it is possible. And we know that FASDs, and I know you're going to talk about it more in your other webinars, are an invisible brain-based condition. And most often, there's no facial features. There's no ability to just detect an individual who may be affected. So anybody could be affected by a brain-based condition. So we begin to ask the question, what if? What if the brain has something to do with behaviors? What if this person's brain really works differently? Really important question to start asking. If you're seeing behaviors that are frustrating and they're the same behaviors that are over and over again, start asking, what if? We know that all of our brains are very different, and we eventually hope to get to the idea where all of our brains are unique and normal for ourselves. That's the idea of neurodiversity, and this is where our research is really heading right now with brain-based conditions. we know that there's lots of different sources. There may be alcohol and other drugs, tobacco even, acquired brain injuries or traumatic brain injuries, genetics, illness, trauma. All of these things can really affect a developing baby. Yet we know that we see the similar symptoms, and this is where the neurobehavioral research came out of fetal alcohol spectrum disorders. We know that there may be processing memory problems, processing problems, or executive functioning issues. And we're seeing those behaviors over and over again in individuals who might be affected. So we begin to ask, what if? What if how our brain works or works differently has something to do with those behaviors that you're observing? And we're going to talk a little bit more about those behaviors. And these are behaviors that could possibly be frustrating and creating anxiety or creating arguments in your home. So we're going to start thinking about linking the brain, remembering what if, with that brain function with our behaviors. So we're going to talk first about what we call primary characteristics. And then we're going to talk a little bit about secondary and tertiary. Those primary characteristics of FAMD are really those behaviors that we're seeing. Those are behaviors that are really associated with differences in the brain. And oftentimes, those are the only indicators that maybe their brain works differently. And these are the behaviors that we're seeing at times that may get somebody into trouble or may create a disturbance in the family. These are our primary characteristics. We also need to remember that strengths are primary characteristics. And everybody has a strength. So when we talk about our primary characteristics, we're talking about a lot of different areas. And at Facets, in our further trainings, we provide what we call an exploration tool that takes a look at all of these primary characteristics in your individual and helps you explore your individual to try to figure out where those primary characteristics might be and what they might be of this person. And by primary characteristics, we say that the first thing we look at is what we call a developmental level of functioning. So what we call dysmaturity, and that is not immaturity. Dysmaturity is really that difference between someone's chronological age and their developmental age. That is the first question that I ask when I'm working with individuals who have brain-based differences. We start to say, how old is this person today? How old is this person developmentally? This person may be 16 developmentally, but sometimes maybe this person may be apparently about 12 years old, and that's okay. And once we begin to really examine where a person is developmentally, then we can start making those really appropriate accommodations for them. That's the very first question I ask, and the very first starter strategy we're going to give you is start to think younger. Just observe. What is a person's developmental age today? We talked too about sensory systems. Is this person easily overstimulated? We think about the environments that we're in, and the environment we're in just in our online classes. Is there any sensory overload going on? Is the texture too rough or sounds too loud? So all of those sensory systems really come into play. We talked too about nutrition. Really important for nutrition. Is this person really struggling in areas of eating? Are they eating too much? Are they eating too little? Do they not have an appetite at all? Maybe they don't know when they're full. These are all areas that we take a look at. Language and communication. Is this person able to talk the talk and walk the walk? Or is this person able to have a really good verbalization, but not quite understanding what they're talking about? Processing pace also goes with that. We all process at different levels. And as you can probably tell, I'm kind of a quick talker. But a lot of times when I work with individuals, and even in my own family, I slow down my words and use fewer words. So is this a person who can process quickly, or is this a person who processes more slowly? Areas such as learning and memory. Can we remember to do 3 things, or can we remember to do 1 thing? Abstract thinking and executive functioning go together. And some examples of abstract thinking, our world is very abstract. A lot of our language is very abstract. Maybe could we use concrete words? We think about executive functioning. Is a person able to kind of globally get things together, or are they able to do 1 piece of the puzzle? and we take a look at strengths. Strengths are so critical. When we think about someone's strengths, and we all have them, we think about their interests, and we think about their natural abilities, and we think about their learning strengths. Does this person learn better one-to-one? Do they learn better in a group setting? Do they learn with hands-on? Are they a better verbal understander? And those are all areas that we can take a look at of an individual that we call primary characteristics. And all those behaviors that we see are giving us clues about what's going on about this individual. We have these primary characteristics, and remember, those are those brain-based behaviors that we're seeing. Those are the only indicators that we're seeing that maybe there's a brain-based difference going on. So what happens when those primary characteristics go unrecognized? What happens when the child who really only does that first step of 3 or 4 steps starts to fall behind in school? What happens with that individual at a job who is not able to get there on time because maybe they have some memory issues going on? So when those primary characteristics go unrecognized, we start to end up with what we call those secondary symptoms. And those are those defensive behaviors that develop over time when there's a poor fit. And by poor fit, I mean poor fit of that environment and accommodations for that person. So it's kind of like imagining if you're a size 6 foot, that somebody buys you a size 4 shoe. And they tell you to put on the size 4 shoe, and you have to wear that around. And after a while, if anybody's ever had shoes that were too small, it gets very, very painful. And so that's an example of kind of that secondary symptom that develops over time. These are defensive behaviors. They're normal reactions to that pain and frustration, and they can be prevented, reduced, or resolved. Examples of what I mean by a poor fit. We think about if an individual really struggles, their FAMB characteristic, maybe they're a visual learner, but they're in a situation where all they have is verbal instruction. And that's our expectation of them. What if they're an individual who processes more slowly? And our expectation is that you're going to be in this fast-paced environment. We take a look at a person who might have difficulty organizing. And our expectation is that they're going to be organized and prioritized. So we can see where that would lead to some issues. This is a great little blurb that we have where it says, for a fair selection, everybody has to take the same exam. Please climb that tree. And Albert Einstein once said, everybody is a genius, but if you judge a fish by its ability to climb a tree, it will spend its whole life believing it's stupid. When we talk about that poor fit over time, we're not recognizing those primary characteristics, so there's that poor fit over time. So we may see somebody who's really easily tired or anxious. Maybe they shut down or they just walk away and get up. Maybe they're very fearful and withdrawn, or they're frustrated and they're angry. Maybe they have a really short fuse. And those can be secondary symptoms over time that happen. We really want to take a look between that fit between their technique that we're using and ability. We take, for example, talking to someone. We're talking to you because maybe you made a mistake, or maybe I want you to remember something more, or we're talking to you to teach you a lesson. And our assumption about brain function is that you're going to be able to remember this. But what if this person has difficulty with memory? So we're going to assume that you can generalize what I'm saying to each situation. But what if that person had problems with difficulty generalizing? We're going to assume that you can process pretty quickly. In order for you to learn a lesson, this is processing quickly. But what if you process more slowly? So we can see where that poor fit over time actually happens. And we remember, just like that size 4 shoe and the size 6 foot, that poor fit over time can equate a lot of problems. And that often, if we don't recognize those primary symptoms and those behaviors as differences in the brain, those tertiary symptoms over years can develop. And this is where we get to trouble in school, social services involvement, homelessness, maybe mental health issues that might go along with that. These can be prevented, and they are preventable. And if a person is at this place, they can be reduced and resolved. Thinking about a good fit. With a good fit, we want to make accommodations for an individual. This is where we start getting into those strategies. So we see these primary characteristics going on, and we see maybe there's some secondary or tertiary. Step back for a minute and take a deep breath. What are some things that we can do? So if we know that an individual is struggling with a characteristic where they're that visual learner, let's provide some visual cues for them. Stop talking and do some visuals. And these seem like really easy accommodations, but they work. If we know an individual processes more slowly, we want to allow some extra time for them. For teachers, oftentimes I tell them if they have to, first of all, if you can get rid of homework, that's wonderful. But if you have to provide homework, allow more time, have the teacher make less questions. And this goes for adults too at work. Have them make less questions so that a person has more time to work on those questions. If we know an individual really needs that external support, that's okay. Then we're going to provide those supports for them. If we have difficulty organizing, we're going to provide some structure, help them go step by step in their organizational process. If we know they're concrete thinkers, we're going to teach them experientially. We're not going to use those abstract terms. And there are tons of examples of success. There is hope. When I first started this, I had a lot of people tell me that individuals who struggle with brain-based conditions really long-term really needed that full support and couldn't have success. I have been in counseling for 20 years. I have seen so many examples of individuals with success. We have had individuals who are incredibly artistic and go on to do artistic things. We have had fabulous parents who really have struggled with fetal alcohol spectrum disorders on their own and become fabulous parents to their children. There is hope, so never ever give up hope. We want to redefine that success from independence. You know, in America, we have this system where everybody needs to kind of be more independent. We really strive for that here, and that's not a bad thing. If that works, then it's a good fit. But if it's not a good fit, why don't we get down to where we start looking at interdependence and community-based? So from our idea of independence to doing everything alone, interdependence would be really working with others. That independence and that expectation of getting a college degree. Instead, what if we turn their strengths into a livelihood? What if we turn, and I have a fabulous neighbor down the street who struggles with a brain-based condition, and he's just started a wood shop and is making good money in his wood shop with beautiful wood creations. And that hurry up and grow up, we have that kind of independence by the age of 18. It's okay if we take that time to develop. We want to start creating a good fit for an individual. And at Facets, if you're interested in what we're talking about tonight, we do provide trainings that give you that exploration tool. And we also help you make those person-centered accommodations. And we're going to start with a couple tonight that really do work for everybody. So by creating that good fit, it really is that systematic approach to developing those person-centered accommodations that work across all settings. In our workshops, we utilize this grid, and we would work with you to teach you how to make your own grids and how to come up with your own accommodations for individuals. So that's just a visual of things that we do. This is a great example. For 16 years, my cat has gotten into the blinds and ruined dozens of sets. We tried double stick tape, squirt bottles, shooing him away, vinegar on the ledge, putting curtains over them. And we have cats that do this at my house. The most simple fix, pull the blinds up 6 inches so they can see out without destroying them. This is from a parent who attended one of our workshops, and she said, NB's kind of like that. We have tried all of these fixes that were really complex when sometimes the most basic accommodation works for an individual. And it's just that something we don't think about often. Remember that creating a good fit is going to lower that frustration and behavior. And remember that creating a good fit is equal is not always fair. You know, equal does not mean fair. It means that providing that accommodation that's going to work for that individual. And every individual is so different. But it does reduce frustration, anxiety. And we also see a reduction in those secondary behaviors, that anxiety, that frustration, that anger that we see. So some starter strategies. Thinking of our starter strategies. We think about home, in school and community, and these work across the board. So one of the first strategies that we talk about is think brain. Really start reframing those perceptions. And we've talked about some different primary characteristics, about communication, processing pace, thinking younger if an individual really displays some younger behaviors in a setting. And so if you're seeing those, start thinking brain. Remember our question where we said, what if? What if this is brain-based? So if we start thinking brain and we start thinking perhaps this individual's behavior is not intentional towards me, it starts to really reframe our perceptions. It reframes our perception about the situation and about that individual, and it can depersonalize the situation. If we're seeing those behaviors of not remembering to do chores, if we're seeing the behaviors of an individual not on time to work, start thinking brain. Is that intentional, or is that a brain-based difference? We think about really observing patterns of behaviors over time. And when we talked about our primary characteristics, I was talking about our exploration tool. And that allows for observation of patterns of behaviors, but you can do it without the tool. Really start to take a look, especially if you're really hitting your head against a wall with an individual. Start observing their behaviors. Think brain first, take a step back, and start observing those behaviors. What patterns are you seeing with them? Is this a memory area? Is this a communication area? Is this a processing pace area? Might it be that their behavior is a bit younger? And so maybe a 12-year-old is not going to be behaving in the same manner as their chronological age of 16. We think about identifying what is going on, identify those primary characteristics, but also identify their strengths. Let's build on those strengths. Remember, if they're a kinesthetic learner, let's give them hands-on learning. If they're a verbal learner, that's great. Maybe some audio learning would work with them. But beginning to understand what their strengths are. Are they creative? Are they great mechanic? Are they a great caregiver? Let's see how we can expand on those strengths. And when we talk about IEPs are individualized education plans. I'm sure Kelly could probably talk a lot more about that. We're talking about IEPs, but we're also talking about treatment plans. We're also talking about any type of plan that an individual would have at work. So this goes across both parental and professional. We want to write that plan for the environment. On all of my treatment plans for my individuals, we put in environmental fits. We talk about making good accommodations for the individual. We talk about teaching families to make accommodations. We talk about primary characteristics in our plans. And pretty much you can write anything into a plan. So if you're struggling with school systems, and I know you all will talk more about that later, you can write in primary characteristics. You can write in the word accommodations. Whatever is going to be modifying that environment for a good fit for that person. Big thing, we want to collaborate, coordinate, and communicate, not only across environments, but with the individual who is affected. One of the easiest activities as a starter strategy that does absolutely no harm is what we call draw our brain. And it is one of the activities I do with all my individuals. All of my children, even the little ones, about 5 and up, can do this. And we have them just get a marker, a pen, or whatever you might have. And we take a couple minutes and we say, hey, how about draw your brain? It's a really interesting exercise. It's something none of us ever think about because we take for granted that our brains are just working all the time. But how often do we stop and think, what does our brain look like working? This is a great communication tool for lots of families. I had a family that I worked with a number of years ago, and the parents were really at odds with a teenager. And the communication was breaking down, and they were so frustrated, and the individual was struggling with a neurobehavioral condition. And as a last resort, we had them just, hey, let's take a night and draw. And it was able to open up so much communication because the teenager was able to tell everybody, this is my brain, and this is how it feels to be in my brain. And this is how it feels to be in the world around me. And what a fabulous way to open up that communication. And so we find that that activity is a really easy one. And it's a great activity if you have somebody who likes to draw or somebody who likes to talk. And it really can be helpful. Some more starter strategies that you can take away from today. Stop fighting and step back. And that, I know that seems like a really frustrating thing to tell somebody, but oftentimes disengaging the battle, stopping what has not been working. Take a step back and take a deep breath. Start asking, what if? What if this is brain-based? What if those behaviors I'm seeing are not intentional? They're not mean. They're not towards me. What if these are some brain-based differences that we can explore? Take that step back and stop the arguing, which can be really hard to do, but is so worth it to do it. Ask. I learned this the hard way in working with a 6-year-old a number of years ago. After we had behavior charts, sticker charts, reward systems, reward trays, toys, just about every type of behavior modification program we could work with, I sat down one day, and this was early on in my working with this model. I sat down and said, okay, we have tried everything here. How about you tell me what's going to work for you? What do you need? What's happening in your mind? We drew our brains. And as we were drawing our brains, the 6-year-old said to me, finally. I said, finally what? And they said, finally you asked me. And what I have learned over doing this for many years now is that an individual who's affected knows that maybe there might be a little bit different somewhere in themselves. And that's okay. But a lot of them are too afraid to say it. And that's one question I ask all the people that I work with now, and my own family, especially when we get into difficulties. We ask, what is it that you need? What's going on with your brain today? And we talk about it. And it is a great place to start because, again, I've never met an individual who's affected who didn't know that they were affected. Another one that's really big is slow down and give more time. And that can be really hard because we live in a 3-second world. You know, we live in this world that demands that we get back to people very quickly. So again, stop fighting, take that deep breath and slow down. Provide less words and slower speech. Think younger. This is one of the first strategies we use, is really take a look at that developmental age. Is it meeting their chronological age today? And if not, that's okay. We just gives us a clue as to what's going on. Observe, you know, what worked 2 days ago, again, may not work today, and that's okay. If we can adapt what we did 2 days ago that works, that's great. Show and repeat. Because remember, if an individual is only hearing that first step out of 3, you may need to repeat those extra steps, and that's okay. That allows you to make the accommodation for them, and it cuts down on that internal battle. And while you're cutting down on that internal battle, it lifts that person up. The person starts to feel success. Because remember, like this tight shoe, that size 4 shoe, that's been going over time. And so individuals oftentimes feel very stressed out and very anxious, and that can show in a lot of different ways. And so if we're helping make those accommodations, what we can find is that people settle. Preventing, that's a huge one too. If you know that an individual, like we talked about, is a visual learner, do the visual cues. If we know that they're a kinesthetic learner, let's use those kinesthetic experiences hands-on for them. And that's going to prevent a lot of that anxiety and stress. Lastly, we want you to take a deep breath and keep breathing deeply. And at the same time, I often tell parents, and in fact, I told a parent this today, not in a religious manner, but to give yourself what we call grace, which is being gentle with yourself, allowing yourself to take a step back, because this is hard. If you're a parent or a caregiver or a professional, this is hard. And I think parents have the hardest job on the planet. Just be gentle with yourself. Know that you're not perfect, and we're not going to do this perfectly 100% of the time, and that's okay. Things are going to turn out okay. We think about, who is this person? And that really does help us as we go along. And again, like we have talked about, if they're dismature, if they're younger, let's think younger. Let's think about some younger activities and ways we can communicate. If they're really struggling with processing, let's slow down and make sure that a person understands. If they have memory problems, let's provide those assists. We use assists every day. I know that if I don't keep things on a calendar, if I don't write things on a sticky note, then I'm not going to remember things. So let's provide those assists for individuals. If they're impulsive, and that is another area that is considered a primary characteristic, that brain-based characteristic, let's assure them safety. Let's help them make smaller choices, but choices that they make. So offer different choices for them. Assure them that safety. And keep it concrete and specific. And that's hard in the English language, I know, because we have a lot of abstract in our language. As we're taking a look, and I know we're kind of coming down towards our end, we think of a paradigm, which is our way of seeing the world. In order to start making those accommodations and start to think brain, it's really a shift where we start seeing things differently. And we say, you know, this is a brain-based difference, or as we use the term now, disability. And we say, I get it. She has the disability. We have to do the changing. We have to provide those accommodations to help them settle. That was actually a parent of a child with FASD who sent that in to us. So lastly, our paradigm shifts. We want to think about our child or our adult, they won't do something. What if we start thinking, gosh, is this a brain-based difference? And maybe they can't do this area, and that's okay. To the person being the problem, to a person having a problem. Remember, it's a physical structural change in the brain that's invisible. From a person who doesn't work, maybe to a person who has trouble starting something. And from a person who maybe acts immature, maybe that's the person we constantly are saying, act your age. What if there was dismaturity there where that chronological age didn't meet that developmental age? And what if it was a person that we think, gosh, this person just doesn't try? What if, like wearing that size 4 shoe again, they were tired of failing. They're tired of wearing the shoe. They're tired of things not being recognized and trying over and over again. Remember that if you change the way you look at things, that the things you look at change. And that is a great quote by Wayne Dyer. Sorry, my voice is going. That's the end of our slides, but I'd like to tell you a story. Let's see if we can get everybody back here. Here we go. And I know you're still seeing my background, sorry. I wanted to kind of leave you all with a story. I worked with a 17, the story came actually to me this week, so it is fortuitous. I worked with a 17-year-old a number of years ago. I'm not going to tell you how old I am, but it was a while ago. And so this individual came to us in the agency I worked with. This person had really struggled. We took cases of individuals who were headed to juvenile detention or adult detention for a very, very long time. And this person came to me and had already been participating in gang activity, was pretty tough kid when I first met him. We can call him Timmy. And Timmy didn't want to have anything to do with me, and I don't blame him. I wouldn't either if I was Timmy. And it took about 6 weeks because I started to notice that Timmy liked to draw and scribble, and that's fabulous. And what I learned as we went along, I started bringing in some art activities for Timmy. And in about 6 or 7 weeks, we started drawing together and started communicating through art. And what I started to realize was there were some processing issues. There was a memory issue, that he had a diagnosis of fetal alcohol syndrome, and that he had missed 90 days of school and had had a criminal record. We started exploring those primary characteristics, and what it came to be after much discussion is that he sat down one day and told me, look, I can't get it together to get to school, so I just gave up. And so the morning was a little too difficult. So getting up, brushing your teeth, taking your medicine, we think about all those things we do in the morning that we take for granted, and we have our kids and adults take for granted. And for him, it was impossible, so he just gave up. And the system kind of let him give up because they weren't able to recognize the underlying things that were going on. We started making some very basic accommodations. We used his artistic skills, and we started creating some little drawings, and it was very tiny, little tiny drawings that we made. He was fabulous at little tiny drawings. I don't do them. And made some little drawings for himself and kind of stuck them in his pocket. And he put them in order, and in the mornings he would get up and check them off one by one. And so instead of going to school never, we got about 3 to 4 days a week of school attendance. And so things started to pick up, and there started to be hope. And hope is just an amazing seed that starts with individuals. I recently, and we kept going with him, he ended up going over to a different school that wasn't so crowded, because our schools are very crowded. was able to graduate. And recently I had heard that he had just gotten a scholarship to a 2-year art program that will allow the certification to use his strengths that he was able to identify. And so I give you that story in closing tonight as hope. So don't ever let anybody tell you that there is not hope. Individuals who struggle with brain-based conditions have such fabulous strengths that will lift them up if we just identify them and help them find that. So don't ever give up hope, and don't let anybody tell you that there is no success, because there's a ton of it. So I think I'm going to stop talking for a little bit. If you want to stop my screen.
Yes, I think I have. I think I am now showing my screen. So that's Melissa's contact information. I think Lisa put that in the chat. And we are also going to put in the chat our evaluation for the session. We don't want you to leave yet, but Lisa's going to put the link to the evaluation into the chat. Those evaluations are really valuable to us because it lets us know if our presentations, our topics, our presenters, our timing, all of those logistics are good for you, if they work for you, or if you have recommendations for other approaches, because we really do pay attention to those evaluations. So it's a very short, like 10 questions evaluation that we would love you to complete after you're done with the session, but please click on that link. There's information about connecting with us on social media, and we hope that you do that if you are not already connected. I'm going to go back to Melissa's contact information, and I think we have some questions that have already come in, and please continue to put your questions in the questions pod and or raise your hand. There's like a little hand symbol, and you can raise your hand and we can unmute you individually. We do have a somewhat large group, so we don't want to unmute everybody. But if you have a question, you can chat it into the question box or you can raise your hand. Lisa, do we have a question?
We do have a question, and it references infants and substance abuse. So the question is, will all infants substance exposed in utero have AFSD?
Not necessarily. I'm sure that as we go along, it sounds like next week you'll be talking more about diagnostics, but not necessarily, because every individual is so vastly different in how they're affected. And so when we talk about those primary characteristics, everybody's primary characteristics might be very different. That's why fetal alcohol spectrum disorders is a spectrum. And so that a person may be a little bit affected or not at all, and a person can be greatly affected. So it just depends.
Great, thank you.
Thank you for that. You did have a great resource reference for your exercise that you showed. I was just wondering, I would like to try it at home, but do you have any recommendations of how a parent can approach a school staff person or a professional and work together, collaborate in using that exercise?
Okay, so I'm assuming maybe using that having the teachers do that exercise?
Yeah.
Okay. I just introduce it, and when I practice with families, I have families do it, I have their teachers do it, their counselors, anybody in their pod that will do it, we have them do it. And what I say is, look, we have this new activity and it helps us communicate with an individual, whoever that individual is who might be affected. Would you be willing to try it? It's fun, it's drawing, it only takes a minute and it can't hurt. And a lot of times they'll say, sure. And I'll say, this may be helpful for you to learn information about your class. And as we know, teachers, my husband's a teacher, they're overloaded right now. Good people, well-intended, but very overloaded, very overloaded. And so if we can provide a small little activity that takes just a few minutes that helps them, it's a win-win. And so that's kind of how we introduce it to them.
Okay, thank you. Next question, are there different strategies for those FASD individuals with ID? They appear to be grouped as autism.
Yes, and let's remember autism, and I know we didn't go into, that's the other thing I wanted to say before I went on, because I feel like I left this out, was that this is just an introduction tonight. If you all are wanting more information, we do provide 6- and 7-week trainings, everything's online. So I didn't want to just leave you. If you have more questions tonight, we can help provide those answers. But as far as ID goes, remember that autism is a neurobehavioral condition. It is a brain-based condition. And so really, even with an individual who may be affected with ID areas, we just take a look at those primary characteristics. How does this person affected? You know, or is it a memory issue? Is it a processing pace? Or is it maybe that the world around them is way too abstract? And so we just start taking a look at those areas while at the same time we look at their strengths. So it really isn't any different for an individual who may be affected around ID.
Okay. Thank you. I'm looking to see if we have additional questions on our list. If you would like to post a question, please use the question pod. We'll give it another minute and see if we have any more come in.
While we wait, I would like to piggyback on that last question because we get that question a lot. We, in special education particularly, we are a very label category driven system. You must have a category to be eligible for special education related services. I think the same can be said for some of the mental health services that diagnoses sometimes are lead the way, even though that maybe runs counter to our best practices. So what is your recommendation, Melissa, to families who are struggling to sort of parse out? There may be some autistic-like characteristics, there may be some ID, there may be some LD, there may be some ADHD, and there may be FASD. So, what's your guidance to them in terms of sort of understanding what's the biggest challenge to tackle first?
Okay, as far as, and let me make sure I have your question right, as far as getting a diagnosis, or as far as working within the school system around them?
I think working with is what we really hear, is that you know, they know that their children have characteristics that could fall into a lot of categories, but the systems they're working with want a diagnosis and they want a program for those diagnoses. So do you have some guidance when you have a very umbrella kid with lots of things going on under that umbrella?
Right. Oftentimes I start with those primary characteristics and start asking are around each of those different areas, because that can also help pull out a diagnosis, because I know we live by diagnoses. I know our system. I'm hoping someday we don't have to, but we do right now. So by actually exploring those characteristics with individuals, with the teachers, with whoever it may be, and have them begin to see, because sometimes they're not seeing all those behaviors, or maybe they don't fit into that one checklist. But if you're exploring those 9 different primary characteristics and letting them hear what you're seeing, they can start doing more observation around patterns of behavior. That can often lend itself to developing better plans, but it can also lend itself to, oh my gosh, we didn't see these 4 things that lead to this diagnosis. So again, it's really observing those patterns of behavior. And if you can have staff do that, that's fabulous. A lot of times, again, if you're saying to them, you know, I know that you're super busy, but how about, can we do 2 or 3 times a week where we're just doing observations? And these are the things I'm seeing at home. And what are you seeing here? And a lot of times that can parse out some diagnostics.
Are we ready for more questions? We have one. Melissa, can you speak a little bit more about what FASDs is, and do you work somewhere else? You mentioned a family you worked with, or is that just an example you were using?
No, I will definitely clear that. I am a counselor for an agency in Roanoke, Virginia. That is my, I guess, semi full-time job. I'm not sure which job it is, but that is where I work specifically with clients who are affected. My entire caseload is always neurobehavioral conditions, and that is the counseling agency I work for in Roanoke, Virginia. With FASDs, it's fetal alcohol syndrome, consultation, education, and training, long verse. And that is specifically, we don't work individually in a therapeutic manner, but we provide education to anyone around how to work with individuals who are affected with neurobehavioral conditions. And so we are specifically education, consultation, and training agency. And we do a lot of one-to-one consultations, international consultations, adoption, kinship, and it goes on and on. But that's specifically where I do the training and education like I do tonight.
Okay. I don't see any more questions waiting, so thank you, Melissa, for your time and your answers. They were very informative. I'll turn it over to Kelly to close out our session for tonight.
Great, thank you. I just want to remind folks that we do have 3 more webinars in our series. Again, next week is a real deep dive into diagnoses and with Dr. Turchi, and I think that will be really helpful for folks that might be new to this topic or struggling to identify exactly what might be going on and how best to get those, unfortunately, diagnostic driven systems to pay attention to some of the needs of their kiddo. It also may be, diagnosis may be an avenue for long-term supports, eligibility for long-term supports. So it will be an important topic. You can register for each of those webinars separately, and that's on through our website. I think Lisa will put that link back in. If you just go to our events page, you can just click on whichever webinars, any or all of the webinars you're interested in attending. And I'm just going to give one more plug for our self-care webinar. After hearing all of this from Melissa, it is a good reminder if you are parenting a child with neurobehavioral challenges, or any challenge, it is always good, especially now during COVID and some of the stressors that we're all facing with our current circumstances, to pay attention to what you need. And so join us lunchtime a week from tomorrow for that self-care webinar. Melissa, I'm going to give you a chance to say anything else, and then I really wish you all a great evening, and thank Melissa again so deeply for spending her time and giving us of her expertise this evening. Melissa?
Thank you. Thank you to Kelly. Thank you to Lisa. Thank you to what you all do. I can't tell you the amount of people from Southwest Virginia I refer to you all. Thank you. Thank you. Thank you for thinking of the caregivers, because this is hard. And that's what I want to make sure. And I know a lot of the accommodations, you might say, gosh, Melissa, that sounds really easy. Good luck. And it could breed that frustration or bring up that frustration. But what I want to say is it's important to validate this is hard. This is very hard. And it's hard for a family. It's hard in the community, especially for parents and caregivers. It's very hard. And that's okay to say it's very hard. It's okay to validate that. That doesn't mean that in any way, shape, or form that's negative. But it's sometimes really important for us to validate this is hard and we know it is. And so give yourself grace, take a step back, and stop arguing and breathe deep for a few minutes. You deserve it. So I want to say thank you, thank you, thank you for coming tonight. Thank you so much for hearing this information. I hope some of it might have interested you. If it does, that's wonderful. Let me know. Let Kelly know. And just take care of yourselves, especially in light of the world we live in right now. So thank you.
Thank you all, and all be safe and warm and well, and we hope to see you next week. Take care.